We'll get going now. Thank you everyone for joining us for this ESSO webinar. I'll just start off by sharing my screen. So my name's Henry Smith. I'm a member of the ESSO's Colorectal Educational Training Committee, and I'm a colorectal surgeon from Denmark, and I'll be hosting this webinar, which will be focusing on the management of acute presentations of colon and rectal cancers. And so we've got a great lineup here with three speakers and a co-chair, which we'll get onto introducing in a moment. But to start off with, we'll just give a bit of an introduction to what ESSO is for anyone who's unfamiliar. So ESSO is the European Society of Surgical Oncology, and it's in reality more of a global society of cancer surgeons, where the aim is to try and improve networking between different specialities and surgeons across the globe, and to promote the message of surgical oncology, so cancer surgeons being at the center of cancer treatment for patients, with a focus on improving education for cancer surgeons and also improving the quality of surgical research that's done in these topics worldwide. There's a number of benefits to being a member of ESSO, and if you want to join, you can scan the QR code there to find out some more information. If you're a member of ESSO, you have reduced rates for registration for the ESSO Congress, which is held each year, and there's also a number of educational activities that ESSO runs that you can benefit from reduced fees for. There's also advantages in terms of subscription to ESSO's journal, the European Journal of Surgical Oncology, and open access fees for that journal. There's educational grants that ESSO provides that help support surgeons who want to go on exchanges to centres of excellence around the world. And there's also an opportunity to assist and promote research activities from different countries, where there's both resources and guidance available to people who have projects that are under development. It also gives you access to a global network of now over 4,000 oncologists, surgical oncologists around the world. ESSO also hosts or is responsible for the European exam in surgical oncology, which is organised in association with UEMS, and it's held annually in conjunction with the ESSO Congress. And more information about that exam and how to register for it can be found by accessing the QR code provided. And as I said before, ESSO has its own journal, the European Journal of Surgical Oncology, which now has an impact factor of 2.9, and publishes regularly original research focusing on surgical oncology, and you can benefit from reduced open access fees as a member of ESSO to that journal. ESSO runs a number of courses as well, and these are just a couple of the courses that are coming up that you can apply for. There's a course on artificial intelligence in healthcare in Lisbon in May, which has a fantastic program. And again, you can find out more about that from ESSO's website. And there's also a hands-on course in laparoscopy for perineal carcinomatosis that's being held in Madrid in September. And there's still places on that course that are available if anyone is interested. The ESSO Congress this year is being held in Madrid between the 4th and 6th of November. The call for abstracts has been recently released, and so it's a fantastic opportunity to come and present the work from your institution and also to meet like-minded surgical oncologists from around the world. So that's what ESSO is, and so now more onto the topic at hand. So we'll be talking today about acute presentations of colon and rectal cancers, and it's a privilege today to be joined by Maj-Britt Erntoft. Maj-Britt's a colorectal fellow, also from Denmark. She completed her surgical training in 2002 and has been a fellow since 2005. She did a PhD in the management in liquid biopsies as a marker for colorectal cancer and how they can be used to also management for these patients, and is now an associate professor at the University of Aarhus and a member of the research unit at Gulstrup Hospital, where they focus on surgical innovation, education, and translational research. She's also leading the group of surgeons who are currently updating the Danish national guidelines on the management of acute colorectal cancer. So it's a privilege to have her here, helping to moderate and providing her own views as well. And so Maj-Britt will now introduce the other speakers that we have, starting off with Eric. Maj-Britt.
Yeah, thank you very much, Henry. And we have an exciting program, so thank you for the introduction, and we'll move on quickly. First of all, I'd like to introduce our three speakers. Eric van der Stok, who is a surgical oncologist. He's working in the Netherlands, and his clinical practice and research activities are focused on primary colorectal cancer and also colorectal liver metastasis. He's an active member of Young ESSO, and he'll discuss strategies and controversies in acute presentations of colorectal cancer in a speak called Acute Colorectal Presentations, Current Strategies and Controversies. Then, after Eric, we'll be joined by William Su, who serves as a surgical registrar at Auckland City Hospital and honorary clinical lecturer at the University of Auckland. And his academic interests focus on surgical recovery and outcomes, and also multi-center collaborative research. William is actively involved in the global research community through previous leadership roles in the Tasman, in Eurosearch, and in Strata Collaboratives. And William will be presenting a speech called Current Approaches to Acute Presentations, Lessons Learned from the Apollo Study. Then we have Daniel Baker, who's a general and colorectal surgical registrar in Yorkshire, England. He is undertaking a PhD researching alternative approaches to managing emergency colorectal cancer presentations. And he's an RCS and ACGBI Associate Surgical Specialty Lead. I hope I said that correctly. In emergency general surgery. And he's also a member of the Colorectal Disease Early Career Advisory Board. And then after all these three great presentations, we have 10 minutes for discussions and questions and answers as well. So feel free to write your questions as we go along in the chat, or you can post.
Perfect. Thanks, Britt. So, Eric, over to you.
Right. Thank you. So yes, thank webinar on acute colorectal presentations. So about 15 to 30% of colorectal cancer patients present acutely. Of course, this number may be declining because of screening programs. There's in literature, there's four different types of acute colorectal presentations. The most discussed and most researched one is the acute obstruction, with systematic reviews and meta-analysis also discussed in this presentation. And then there's, of course, perforations, abscess, and bleeding, with almost no literature for strong recommendation, let's put it that way. And we'll shortly touch on those as well. For acute colorectal presentations, and this is basic knowledge, of course, but the most important diagnostic is a CT scan. And what you're looking for is free air, free fluid, contrast extravasations, but also you should pay attention to tumor location and length. If there's a locally advanced setting, yes or no, and if there's potential metastasis. This is a patient we treated a couple of months ago in our clinic, 74 years old male. This is his CT scan, and as you can see, there's a completely distended colon. Shortly, you'll see a tumor in the sigmoid. His small intestine is not dilated, and so Bowens valve is patent, and we gave this patient a decompression transfer stoma. After he recovered, we did a full workup with colonoscopy, showing a stenosing tumor at 18 centimeters. It was a CT3N0 sigmoid tumor. We did a robotic resection. This is his final pathology report. He just finished adjuvant systemic therapy and will have a completion colonoscopy and reversal of his colostomy in a few weeks. Now, this is just an example of how to tackle an acute obstruction, but of course, there's more options for this patient group. This patient group, so acute obstructions specifically makes up about 13% of all patients with colon cancer. But it really is a different group than all the others with colon cancer. If you look at postoperative mortality and even long-term oncological outcome, they really do perform worse. And everybody knows why. These patients don't have an appointment in your outpatient clinic through a screening program. They present in the emergency department. Most of the time they're old and fragile. They're malnourished, dehydrated, and they have a distended abdomen, which imposes technical challenges in terms of abdominal surgery. So this patient group really is different, and there's a couple of main items to tackle. The first, of course, is survival. We need to save them from a deadly condition. But also at the same time, already at presentation, there are some oncological items to address. And I think the main question is, are we going for a bridge to definitive surgery, a strategy, or for an acute resection? So to make that choice, there are some oncological considerations. Are we going to treat the patient with curative intent, yes or no? And is there a locally advanced setting of the primary tumor? And then there's also some technical, metabolic or timing considerations. Are we going for a bridge to definitive surgery strategy where the patient gets a chance to recover from his acute presentation, and we can do adequate staging and make an adequate oncological plan? Or are we going for an acute resection? If you do that, you need to take into account oncological principles, and that can be challenging in a distended abdomen. And also, it's important to take into account that minimally invasive surgery is almost impossible in these patients in the acute setting. Of course, when there's a peritonitis and an unstable patient, you have no other option than an acute resection. So what options do we have if we go for a bridge to surgery strategy? Well, like in the case I presented, you can go for a decompressing stoma. It has some disadvantages. You probably need 2 or 3 surgeries for the total procedure. The other option is to go for a stent. Now, stenting has the advantage of avoiding a stoma in 70% of all patients with acute obstruction. But it also comes with some disadvantages. In 7% of patients, you get a perforation due to stenting with worse oncological outcome. And also in right-sided tumors, even experienced endoscopists will be hesitant to place a stent. So you should only do this if you have good endoscopists in your hospital. So those are the main 2 bridge to surgery strategies, but there's a new kit on the block that I would just like to mention shortly. This is now up and running in about 4 hospitals in the Netherlands, where you don't need any major intervention at all in the acute setting. You just place a nasogastric tube and you give TPV. You start in clinic, you start prehabilitation and do a resection in 7 to 10 days. And with this obstruction protocol, we just published an evaluation. We were able to avoid stoma, stent, or acute resection in 75% of patients. So I do believe this is promising. Okay, so how do all these bridge to surgery strategies perform in terms of outcome? So, and there's strong enough literature here, systematic reviews and meta-analysis also included in all guidelines. So in the curative setting for non-locally advanced cancers, left-sided, decompressing colostomy was superior to acute resection in terms of mortality, overall survival, and the need for permanent colostomies. When stenting was compared to acute resection, we see the same pattern. So in terms of mortality, overall survival, the need for permanent stomas, stenting is superior to acute resection. And then there it is again. Stenting also comes with a perforation rate of about 7%. So that's something to take into account here. For right-sided tumors, there's much fewer research. But what you see is the same trend in terms of mortality and morbidity. So stenting is superior to acute resection for right-sided tumors. Then for tumors at any site in the curative setting with a locally advanced stage, a bridging strategy is advised because those tumors do need neoadjuvant therapy in terms of oncological outcome. And then in the palliative setting, both left and right-sided tumors, stenting again is superior to acute resection in terms of mortality, complications, and stoma rate. However, with stenting, you see more late complications, and that's mainly due to obstructive complications. So then if you look at guidelines, there's a common denominator. There's agreement in terms of the fact that resection in the acute setting is still accepted for non-advanced disease. However, all guidelines acknowledge that bridging does come with decreased morbidity and mortality. Stenting is the most elegant bridging strategy in experienced centers, and otherwise colostomy or ileostomy is a good alternative. In locally advanced disease, bridging is preferable due to the the indication of neoadjuvant treatment. And in the palliative setting, stenting is advised. And then one slide on perforations and bleeding. So if you look at all those guidelines for perforation, there's not so much literature, but if there's a perforation, it does imply that there is locally advanced disease and that the patient needs neoadjuvant treatment. So if the condition of the patient allows for bridging, that's preferred. So with only pericolonic free air or abscess, bridging with or without drainage is advised. But of course, if the patient is unstable with peritonitis, distant free air, acute resection is needed, segmental or subtotal. And then for bleeding, coiling would be the first step. If that's not feasible, if the patient is too unstable, if coiling didn't work, acute resection should also be used as a last resort. So yes, that's how I would like to conclude my presentation. So I give the floor back to the chair people.
Perfect. Thanks, Eric, for that comprehensive overview of where this data is. There's been a couple of questions that we'll try and answer as we go along. If there's any others that are more general, we'll take them at the end in the plenary session. But so now we'll move on to, so now we know what we should do or what maybe there is some evidence to support. And now we'll have William come and present some real world data from the Apollo study, which will be which we're all looking forward to. William.
Thanks, Eric, and thanks to the chairs and ESSO. So today I'll be talking a bit more about the current approaches to acute colorectal cancer presentations, presenting some data from the Apollo snapshot study. So as we've already heard today from Eric, colorectal cancer presents as an emergency as many as 1/3 of patients. And we've also heard that these cases are associated with increased mortality, morbidity, as well as poorer long-term health-related quality of life. I like that there's a theme coming along here because there is a paucity of large-scale global data to guide management and guidelines in acute presentations. And this is really what motivated us as a collaborative to design the Apollo study, which was a snapshot prospective multicenter study. To date, we've published 3 papers and manuscripts from the study, the first of which looking at global variation in emergency colorectal cancer surgery, and this was in particular looking at outcomes of emergency curative surgery across different countries and income settings. We looked at the global use of endoscopic stenting, in particular left-sided colonic obstruction. And we also looked at a general snapshot of how patients are presenting, how they're managed, and what the general outcomes are. And my talk today will be focused more so on the third manuscript, but with also some bits and pieces from the other studies as well. So our aims of this particular manuscript were to understand the global patterns in acute colorectal cancer presentation, to describe surgical and non-surgical management approaches, and lastly, to characterize 90-day outcomes. The Apollo study was a prospective observational study open to all hospitals conducting colorectal surgery across a range of different countries. And this was following a collaborative model where at each center there was a local team of a supervising consultant, leading junior doctor or registrar or fellow, as well as a team of data collectors. And we also had independent data validators at each center, which who their responsibility was to make sure that all cases were included and they validated accuracy on 8 key variables. Patients were included from any 6-week continuous period from January to June in 2023, and consecutive patients were included, and data were uploaded to a secure Rectal online database afterwards. So we included any acute hospital admission for patients with colon and or rectal adenocarcinoma. And this could have been index or first presentation or acute presentation due to symptoms in a known cancer. We did, however, exclude patients who are presenting for predominantly side effects of chemo or radiotherapy, as well as non-colorectal cancer primaries. So this was truly a global effort, including nearly 40 countries, over 200 hospitals, and over 2,000 collaborators. In the end, after exclusions and data cleaning, we included 1,861 patients. In terms of general demographics, median age was 70, there was a slight male preponderance, and 45% of patients were ASA 3 to 4. About 3/4 of patients were from high income country settings. Now, we then split up this cohort based on their location and their presentation type to better understand how each presentation is managed. Because obviously, as we've heard, depending on where the cancer is, how advanced it is, and what they're presented with, we do different things. The majority of cases were colonic cancers, about 80%, and split more or less evenly between right and left-sided colon cancers. The remainder of the cases were either rectal cancers or a small proportion of patients with synchronous cancers, and these rates are consistent with what we know from existing literature. In terms of right-sided cancers, the majority of these presented with obstruction. At about 50%, there's about a 12% perforation rate, and then other reasons for presentation included GI bleeding, so gastrointestinal bleeding, worsening pain, and a range of other complications such as abscess. In terms of left-sided colonic cancers, obstruction was a bit more prominent and common, but the perforation rate was about the same. The reasons for acute presentation in rectal cancer was more heterogeneous, and the main reasons, although not listed here, are things for like GI bleeding, pain, etc. And lastly, in this small synchronous cancer cohort, reasons for presentation were rather heterogeneous as well, but this was a small subset of the entire cohort. A bit more in terms of tumor characteristics, about 50% of patients presented at an advanced stage with nodal spread, so at least stage 3 disease, and then about 30% presented with metastatic disease as well, and that was noted clinically. Most cases, about 60%, were treated with curative intent, about 40% of patients were managed palliatively. And most cases got some sort of surgery, and stenting was relatively uncommon. This is a funnel plot which depicts the provision and rates of emergency surgery by centre. And just walking through this, each dot represents a different hospital. On the x-axis, we have the total number of patients included by that centre. And on the y-axis is the proportion of those patients included that underwent some sort of emergency curative surgery. The dark black line is the median, and the dotted lines represent the 95% confidence interval. And the fact that there are some hospitals that lie outside this represents the fact that there is significant variation in the rates of curative cancer surgery conducted when a patient comes to a hospital for acute colon or rectal cancer. About 1 in 2 patients ended up having emergency surgery on a presentation after adjusting for confounding factors. So what did we actually do as a global community in terms of managing acute colorectal cancer? Well, here you can see a few different types of interventions. You can have no surgery, you might have some sort of laparoscopy or just exploratory laparotomy. You can have a diverting stoma only, some sort of resection in stoma or a resection in primary anastomosis. And these are obviously broad categories, but we picked these to make some sense of rather heterogeneous management strategies. And starting with right-sided cancers, as you can see here, the most common kind of management was actually a resection in primary anastomosis across all presentation types. In left-sided cancers, when we try to manage with curative intent, it becomes a bit more heterogeneous, and we tend, the data seem to suggest that we tend to reach for a resection in stoma or a Hartmann's procedure. And this was especially apparent if patients had a perforated cancer. And because other reasons are relatively heterogeneous, management strategies are also a bit more heterogeneous as well. Although left and right-sided cancers, there seems to be some level of consensus. In rectal cancer, the management is quite heterogeneous. So the most common 2 strategies seem to be diverting and acting as a bridge to surgery, or upfront resection with an stoma. And this was particularly apparent in perforated cases. In terms of palliatively managed patients, as we can see, a lot more patients just did not get surgery at their index presentation. But when the right-sided cancers did, it was a mix between mainly diverting stomas and resection in primary anastomosis or resection in stoma. In terms of left-sided cancers, again, a split between diverting stomas and resection within stomas. And then in rectal cancers, seem to favor more just diverting stomas only, but again, some cases get resection as well. Just a note on colonic stenting, only about 5% of our included cohort underwent colonic stenting. And the majority of these cases were for palliative intent and probably for the aforementioned concerns of oncological outcomes as well. And in those who did have a stent in a curative setting, about 40% of those ended up having a bridge to a resection within 90 days. It should be noted that only about 20% of centers actually performed colonic stenting in the study, and the large majority of these were in high-income settings. This is a brief overview of survival within 90 days, and those with curative surgery, as well as no surgery but a curative management strategy, survived much better than patients unfortunately undergoing palliative management. And another way to look at this is looking at the overall mortality rate. So the overall mortality rate in curative surgery was about 7.3%. But if we include non-operative patients and as well as palliatively managed patients, this rises to about 17.5% in line with known data. So, in conclusion, there is significant variation in the emergency management of colorectal cancer globally, and the mortality remains high at 17.5%. Based on our data from the Apollo study, there is a significant opportunity to streamline and standardize the management of emergency colorectal cancer surgery worldwide. I'd like to thank all our collaborators and the patients who made this study possible. Happy to take any questions.
Brilliant. Thanks, William, for that overview of what is a fantastic body of work that's been put together in those studies. And I think it's really hammers home that these are sick patients. They're very comorbid. They have very advanced disease, and still there's a lot of them where we jump in and we do big surgery. So that's very interesting in and of itself, and I think that leads quite nicely on to the presentation that Dan's gonna give now. So Dan, over to you to look at some new strategies that could come in the future.
Thank you. Okay. So yeah, thanks for the opportunity to speak. And essentially, what I've been asked to speak about is strategies that we can potentially take to avoid acute resection. This has already actually been touched upon by Eric, and I'm hoping that we can build on this from this presentation. But what I'll talk about really is sort of the current evidence around acute resections, which again we've already heard a little bit about. The evidence behind the potential alternatives, and also where we think these alternatives could potentially lead to changes in management in the future. I'm specifically going to focus on colonic cancers because I think this is where we've got the most to gain. And generally speaking, rectal cancer management is moving towards the bridging approaches and avoiding acute resections. So I think the first thing to highlight is that it's really important for us to identify the population where we think resections actually can be avoided. We know that the three most common presentations of acute colonic cancers are perforation, lower GI bleeding, and obstruction. In the presence of perforation, we've already heard there's unfortunately little option other than acute resection. In the case of lower GI bleeding, it is something that's common. However, rarely it does end in acute resection. So whilst it may be possible to improve these patient outcomes, it's really outside the remit of this chat about avoiding acute resections. So ultimately, really, there's only one true cohort where we can attempt to reduce the number of acute resections. And this is the obstructing colonic cancers, and specifically those that are deemed curative. I've specified curative as an approach because palliative resections are a bit more of a nuanced area in terms of decision making, and they don't particularly happen in large volumes. So there's not too much evidence that I can present. And just to clarify, what we mean by the term curative is essentially would be someone presenting with what is deemed a surgically resectable tumor, but in the absence of distant metastases. So in terms of acute resections, this has been touched upon already, so I'll very briefly cover this again, but I don't think anyone's really under the illusion that an acute resection for an obstructing colonic cancer is a good outcome for the patient. There are a number of challenges faced with these patients, particularly operatively. There's very high risk of laparotomy and stoma formation, which brings with it increased morbidity and mortality. Patients themselves are often malnourished and deconditioned, particularly from being subacutely obstructed for a number of weeks prior to the presentation. By definition, obstructing cancers are typically more locally advanced at presentation, but they're often not fully staged prior to the acute resection, which brings into question whether the disease is actually even surgically resectable in the first place. For example, the decision for a resection might change in the presence of lung metastases that aren't identified on the original preoperative imaging. Lastly, there are system challenges with acute resections. They're often performed out of hours, and they may not necessarily be performed by a colorectal cancer surgeon. It might be a slightly controversial statement, but I would ask everyone to consider whether they would be happy having an acute colonic cancer resection performed in an emergency by someone that isn't a colorectal cancer surgeon. But again, that is something that's particularly controversial. And I think this is particularly prudent given that obstructing cancers are typically more locally advanced at presentation. So by definition, they're more technically challenging to receive an Arnold resection. But that's the last I'll say of that. Just to highlight the current deficit between emergency and elective resections, I've summarised the evidence here. So there's a 4 times higher risk of 90-day mortality and a 3 times higher risk of significant surgical complications in emergency resections. And what I mean by significant risk is anything that's clavien dindo more than 3. As a result of this, patients presenting acutely, unfortunately, only 30% of those actually make it to adjuvant chemotherapy. And actually, the literature says the most cited reason why patients don't receive adjuvant chemotherapy is surgical associated morbidity. So it's not that the oncologists don't want to give it to them, it's because what we've done to them. There's an observed 30% reduction in 5-year overall survival for patients undergoing emergency resections, which some people would argue is actually due to the significance of disease at presentation as well as the comorbid patient population. But again, there's a number of studies that highlight that emergency presentations are actually an independent risk factor for survival, even when you adjust for patient and tumour-related factors. This therefore, for me, suggests that there's a deficit in the perioperative management of these patients, which could be attributed to the lack of adjuvant treatment. As I've already touched upon, there's a significant risk of an R1 and R2 resection in emergencies. There's little published literature regarding this, unfortunately, but the best available evidence we have shows that roughly a 25% risk of an incomplete resection in emergency presentations, which obviously has an impact upon recurrence rates. So what is the alternative approach? And Eric's already touched on this, but the alternative approach essentially is what we call a bridge to surgery approach. And that's really the only viable alternative in an obstructing colonic cancer. When we take this approach, a patient presenting with an obstructing cancer is either defunctioned via a loop stoma or endoscopically decompressed via a self-expanding metallic stent. A bridge to surgery approach will resolve the initial obstruction and avoids the acute resection, which provides a bit more time for staging CT scans and hopefully an MDT discussion. And there's also a period for patient optimization. It also brings in the possibility of neoadjuvant chemotherapy prior to a definitive resection, which is organised on an expedited basis, but is technically an elective resection and can be performed by a colorectal cancer surgeon. So what is the best evidence to support this approach? Well, there's a much greater volume of data to support bridge to surgery approach in left-sided cancers, which are defined as distal to splenic flexure within the literature. International guidelines do say that a bridge to surgery approach in left-sided cancers is equivocal to acute resections, and it can be considered a viable alternative. But that being said, there is also little evidence to support a two-stage approach in patients who are fit for resection acutely. And the same guidelines generally only recommend a bridge to surgery approach in patients that have borderline fitness. Unfortunately, most of these studies investigating the bridge to surgery or staged approach are actually predating 2010, which is obviously not in keeping with modern oncological treatment options. What is clear from the literature is that the bridge to surgery approach in left-sided obstructions reduces morbidity and mortality and increases rates of minimally invasive techniques at definitive resection, as well as decreasing stoma formation rates. In theory, reducing morbidity should lead to better access to adjuvant chemotherapy, given that this, or should I say, surgical morbidity is the primary factor that currently inhibits its use. But there's no evidence to support this claim, and oncological outcomes are unfortunately poorly reported in surgical studies in the literature. There is also the question about quality of life for these patients, particularly by increasing minimally invasive approach and reducing stoma formation. But again, this is something that's not supported in the current evidence. So in terms of right-sided cancers, this is a recent review that our group have recently published. But essentially, it's generally lower quality data when compared to left-sided cancers. There are issues with selection bias, and principally the literature investigates whether it's actually feasible to place a stent in these patients rather than the bridge to surgery approach as a whole. Over 75% of the patients in this study that we conducted actually underwent an acute resection. 24% had a stent and only 1% had a stoma as a bridge to surgery. There's a lack of reporting of oncological outcomes, which again makes comparisons difficult, and that's demonstrated by the table at the bottom here. Although the evidence is of lower quality, the trend in the data is similar to that seen in left-sided cancers, in that taking a bridge to surgery approach does show lower morbidity and mortality, increases rates of minimally invasive approaches at the definitive resection, and also decreases the stoma formation rates. And while stenting is technically more challenging, it does remain a feasible and safe option for those that are able to place stents. However, due to the lack of data in right-sided cancers, international guidelines currently don't recommend this approach in right-sided obstructing cancers, and instead recommend an emergency resection in those that are fit. We've already seen this graphic from William, but as we just to sort of touch upon it again, despite the evidence, bridge to surgery approaches just aren't utilised in clinical practice at the minute, and the overwhelming majority of patients undergoing acute colonic resection. So really, it's about discussing the barriers, and I've tried to summarise what the barriers are, particularly in the UK. There are well-documented system-related pressures with endoscopy capacity, particularly when there's a new emergency. Obviously, has to sometimes bump an elective patient. It's technically challenging to place a stent in cancers, and not every endoscopist can or is willing to attempt to stent in these patients. There are fears related to tumour perforation, which we've heard the data about, but generally this is fear rather than it being high risk, and the current evidence supports stent placement and reports an 85% success rate, although this is higher in units that are experienced in colonic stent placement. Even if a stent's not deemed possible, there's still the possibility of a defunctioning loop stoma, but this again is not commonly utilised, particularly in right-sided cancers. Whilst this is mainly anecdotal and is probably my experience from within the UK, that generally the mentality, particularly from surgeons, that if the patient's having a general anaesthetic and they're fit enough to have a general anaesthetic, there should be an attempt at the definitive resection at the index procedure, which obviously, as we've already seen, that results in much higher R1 and R2 resection rates. This is often more apparent in right-sided cancers, in my experience, where a right hemicolectomy is felt to be an easier operation for the non-colorectal surgeon. Again, maybe slightly controversial. And one thing to consider as well is also the patient views. I think it's quite a psychologically challenging thing for a patient to potentially, not remove a cancer at the initial operation, even if it is deemed curative at the initial presentation. So despite the known inferior outcomes in emergency presentations, the surgical management of obstructing colonic cancers hasn't changed, even with the advances in oncological treatment options. Whilst no one's under the illusion that surgical resection will remain the definitive management of these patients, we have to ask the question as to whether patients presenting with an obstruction can be de-escalated with relatively less risky initial approaches, with definitive resection performed electively. The only way really we can answer this question is through well-powered research into alternative approaches, with a particular focus on whether it actually confers better oncological outcomes for these patients. For me, left-sided and right-sided cancers should remain as two separate cohorts, as ultimately they behave as two different disease processes. As I'm sure you're all aware, right-sided colonic cancers are typically more advanced at presentation and have a high proportion of dMMR tumours in comparison to left-sided cancers. And some studies actually report the dMMR status for right-sided cancers as high as 30%. So for me, this actually makes right-side obstructing cancers the ideal target for bridge to surgery approaches, as the poor prognostic features suggest they're more likely to confer the most benefit from oncological treatment options, despite the initial, including the initial downstaging through the neoadjuvant treatment options. Despite this, research is primarily focused on left-sided and rectal cancers due to the perceived difficulties that are seen in achieving R0 resections. The difficulty we have with research in this area, that there's still currently a number of unknowns that limit the conduct of research in this setting. This includes surgeon equipoise, patient acceptance, and also unknown recruitment rates in this setting. There's also the question of how best to establish histological diagnosis and MMR status acutely should this be a new presentation. Obviously, this is logistically much easier in left-sided cancers due to the endoscopic access. But in right-sided cancers, it can be particularly challenging, especially if the patient has a defunctioning stoma. A colonoscopy without bowel prep is obviously challenging, and we can't give bowel prep in patients that are already defunctioned. So really the only alternative is to do a colonoscopy via the efferent limb, which is a viable option, but I know there are fears around injury to the stoma or detachment, particularly if this is a new stoma. I'd just like to use this as an opportunity to slightly plug the research that we're going to be doing in the UK. So this is the MROC UK study. So our research group is going to be conducting a body of research soon to establish the feasibility of a trial to assess bridge to surgical approaches in right-side and obstructing colonic cancers. We're going to utilise several work packages to hopefully address the current barriers to research in this setting, and we're hopeful that this will go some way towards designing a definitive trial. We're particularly keen to hear from UK-based surgeons that might be interested in this study if anyone's on the call, and I'll provide my email at the end if you want to get in touch about it. And just a little bit about potentially where this could head in the future. So I'd quite like to highlight ctDNA as something that could potentially change how we manage emergency obstructing cancers. The current research focuses on ctDNA in the elective setting and how this can guide adjuvant treatment, particularly in stage 2 and stage 3 colonic cancers. In the context of obstructing colonic cancers, there isn't actually any research with ctDNA, which is something we're working on. But the data does suggest that advanced colonic cancers, such as T4 or N2 tumours, have high levels of ctDNA, with best data actually suggested between 90 and 95% of these patients are ctDNA positive. This could be really helpful in the context of obstructing cancers, as MMR status can actually be established from ctDNA samples. The two studies that I've put on the slide here have shown really high levels of accuracy in establishing MMR status from ctDNA. And should this actually be translated into clinical practice, we essentially remove the need for an endoscopic examination for patients presenting emergently. So as I come to the end of this presentation, I just want to touch upon what the potential pathway for these patients could look like. So at the top is a summarised version of how the vast majority of patients are currently managed. So when patients present with an obstructing colonic cancer, they generally undergo an acute surgical resection at the minute, which is usually via a laparotomy. Following the acute resection, the patient's usually staged and the case is discussed at the MDT alongside the resection histology, and recommendations for adjuvant chemotherapy are discussed. And just to reiterate, on this current pathway, only 30% of patients actually receive adjuvant chemotherapy. The bottom half of the slide shows what a future pathway could look like if a bridge to surgery approach is adopted, but also incorporating evolving techniques. The patients presenting with obstructing cancer would undergo their initial decompression via a stent or a defunctioning stoma. They would also have a pre-operative blood test for a ctDNA to ascertain their MMR status. Following the initial decompression, staging CTs can be completed and the case discussed at the MDT as to whether the patient may benefit from neoadjuvant therapy prior to the definitive resection. Regardless of whether these patients actually have neoadjuvant treatment, a definitive resection will be planned should the disease be deemed resectable by the MDT. Whilst awaiting the definitive surgery, the patient can be optimised nutritionally and physically where possible. At the definitive resection, there's a much higher chance of minimally invasive techniques, as we've already discussed. And then following the definitive resection, there's a further MDT discussion with both the resection specimen and also the post-operative ctDNA status, which will guide the decision as whether the patient requires further adjuvant treatment. So before I go on to take questions, I just want to leave you on this. So I'm under no illusion that the bridge to surgery approach is challenging monitoring management. It's also something that's not proven as an alternative at the minute, particularly in right-sided obstructing cancers. It's going to be very difficult for us to conduct research in this setting for a number of reasons, which I've already discussed. So will this approach work and demonstrate patient benefit? It might do, but it also might not. But what is clear is that this patient population have poor outcomes. And if we do have a method of approach which could improve that, why not try the experiment? That's my details. I've popped a QR code on which links to my email if people want to get in touch and discuss anything within the UK or just as a whole. Shall I just leave this up for two, Henry? Is that okay? Just shout at me when you want me to take it down.
Very good. And I think it'll disappear as soon as I start saying anything. So
yeah, I'll give it 10 more seconds and take it down. Cool. Thank you.
Thanks a lot, Dan. That was a great talk. And be really interesting to follow in your endeavours and see where you end up. I think it's one of those interesting things to think as well. If what would we want if we were patients who were presenting with those same conditions? I know if I had a right-sided cancer and I presented with an obstruction, I'd want to know what my mismatch repair status was before someone laparotomied me. So I think it's going to be that way that things start to move. and it'll be the question about how many patients we can actually avoid performing acute resections in. So thanks to all the speakers. I think we've had a fantastic trip around the nuances and controversies in managing these patient groups. There's been some questions in the chat, and I think there's a couple, Eric, that are directed to you about your nasogastric tube and PTV approach, and people who wanted a few more details on that. If you'd be able to just give a bit of a broader summary.
Yes, of course, I'd be happy to. So this is a protocol that is up and running now in, I would say, about 4 hospitals in the Netherlands. Patients with acute obstruction are put in this protocol, and they are the protocol has 4 stages, stage 1 to stage 4. Where stage 4 is a fully distended colon on the CT scan with a cecum of 9 centimeters or more, with or without sepsis or other signs of peritonitis. So when a patient is in this stage, emergency surgery is performed. But the other stages, 1, 2, 3. So stage 3 would be abdominal pain and a fully distended colon on the CT scan. So those patients get a TPV, nasogastric tube, and will be assessed every day by a surgeon. And every day we evaluate if a patient can stay in stage 3 or is downstaged to stage 2, or deteriorates and is upstaged to stage 4 for emergency surgery. So that's really important about this protocol, especially in elderly frail patients, that every day these patients are reassessed in terms of where they are in the obstruction protocol. But what we see is that 75% of patients with a nasogastric tube and TPV can be downstaged within a couple of days to stage 1. So just abdominal pain and rumbling, a low fiber diet, and laxant. And in this patient group, we start prehabilitation in the hospital, and they get a workup. So we can do colonoscopy. We can even prepare them adequately for colonoscopy. And then we perform an elective resection within 10 to 14 days. So I think the upside of this protocol is that those patients don't get a stoma, don't have to be stented. Downside is they have to stay in the hospital for the whole period. And they get a proper oncological workup. So that's the protocol.
Thanks, Eric. Yes, it sounds very impressive. The results that you get there. There's the question: TPV, is that total parent? Is that
nutrition?
Parental nutrition? Is that's the Dutch version of it? Yeah,
exactly.
So everyone else is
thanks.
On board. There was a question about what the turnaround time for mismatch repair status in our hospitals. Our hospital, it takes probably about the same time as every other pathological assessment. It takes sort of 7 days or so. But the ctDNA angle was very interesting, Dan. And I don't know, Maj-Britt, you're in the ctDNA world in Denmark. Is that anything that the groups looked at before in terms of the accuracy of?
As far as I know, nobody in Denmark's been using ctDNA in an acute scenario, but it's true what Daniel says, that all circulating DNA carries the mutation of any tumor. So it's just a question of whether you're looking for DMMR or something else. I think research until now has been focused on personalized markers, especially, or general markers for screening or something like that. But you could just as easily do a sequencing, or you could have like an assay for KRAS mutations and DMMR mutations that you run on the ctDNA. So it's just a question of whether to do it or not. I think in Denmark, Daniel, we would have a problem running those tests to begin with because it's not a common test to run in ordinary labs at ordinary hospitals. How are you moving about that scenario?
So I think it's very theoretical at the minute. So this is the whole thing around the ctDNA, particularly in the acute obstructions, is very theoretical, particularly within the UK. I think the presentation was more just to suggest where it could potentially head if it was something that became routine. Obviously, there's a lot of interest in ctDNA at the minute in the elective setting, and I think that's one of the main things we've had a lot of resistance to with doing the sort of the bridge to surgery research and potentially a trial in this setting in the UK. Is the first question is how are you going to get a tissue diagnosis? So it's almost a suggestion of how we can overcome that in the future. I don't think it's an immediate thing by any means, and I think in the short term we're definitely going to have to think about how we do get that tissue diagnosis, which, as I say, is probably going to end up being a colonoscopy via the front limb of a stoma, or if we do manage to convince someone to actually stent one of these patients, then they can take biopsies at the time. So yeah, we haven't found any way around this yet. It's just something that we have in the back of our minds for a potential future horizon.
I think it's a great idea because those tumors will definitely release ctDNA. The larger the tumor, the more ctDNA. So I think that's it would be okay to sample just as long as you maybe sample more than just 4 mLs of plasma.
Yeah.
Thanks, guys. I think it's one of the other interesting points today. There's no rush to get that diagnosis. So if you've defunctioned someone, you're going to wait a couple of weeks before you do anything else to them as well. So it doesn't need to be an answer you get the next day. It could be an answer you get within a week's time. And worst case scenario, if there's a pMMR tumor, you'd probably consider giving them neoadjuvant treatment anyway. So it's one of those things where it's just changing that approach to these patients, that you don't need to jump in and get everything done when they come in. It's perfectly fine to stay out of trouble and have a bit more time to figure out what to do with them. There's another question about your approach, Eric. It's very popular. Is that the routine approach? You said it was 4 hospitals in the Netherlands. Is it becoming more widespread, or is it something that's still quite local?
So Jennifer Schijnemakers is a colleague of mine, and she's completely right. So it started off in 4 hospitals, and now it's adopted in many more. And it's a part of a larger registration study, the OC-BRIGHT study. You can find it in the chat, where we specifically look at treatment of right-sided obstruction. And then this is one of the accepted bridging strategies. But yeah, so many more hospitals are implementing this. Yeah.
So Henry, I've got a question for William, if it's okay. William, I think you summarized very nicely that we don't agree on how to handle these patients. And also with the knowledge that we've shared today, we actually don't do what the research recommend. Did you look into why it's so difficult to do the same thing and why there's so diverse opinions on how to manage this disease?
Yeah, thanks for your question, Margaret. Tricky. I think my thoughts on at least the data from Apollo study is that while we tried looking at the data in a few ways and find the best way to present it in a coherent way, and we looked at if it's people managed differently because of staging, is it because of presentation, is it but no matter which kind of way we explored it, it remains heterogeneous. And I think a lot of it is to do with the fact that these people come in at 1 a.m., 2 a.m., they're obstructed, they're sick, and you don't really have anyone to call on to be like, oh, can we bridge this person and go and do something? I think surgical dogma, and for good reason, because we know at least these operations get people out of trouble, means that people will try and do the operation that they know and they've been taught, and that may not always be the same thing across different centers. So I think that largely is what resulted in the variation in management as well, especially given that these are, as we've heard, high-risk comorbid patients, and the priority often is just to get them out of trouble. So yeah, to answer your question, we did try and explore why management principles or strategies were different, but unfortunately the data didn't give us I guess the clinical reasoning behind it at 2 a.m.
Thanks, William. I think we're running out of time now, so we've managed to have quite a good discussion about those different bits and pieces. If there are any questions in the chat that we haven't managed to get around to, we'll try and send some answers out to those after the webinar. And then the webinar, it will also be available on the ESSO website within the next couple of weeks, usually. So I'd like to thank all our panelists. It's been fantastic having you here. Thank you for taking the time to come and share your expertise and your opinions. And thank you all for joining us. And that's the last in the current series of webinars from the Colorectal group. But we'll see if we can come up with some more in the near future. So everyone have a good day or a good evening, depending on where you are in the world. Bye now.